This is Larry Badur. I'm a professor emeritus in medicine with the Departments of Medicine and Cardiovascular Medicine, Division of Public Health, Infectious Diseases, and Occupational Medicine, Mayo Clinic, College of Medicine and Science in Rochester, Minnesota. Before we get started, I would like to highlight that this work was led by Martin Thornhill. He's from the Unit of Oral and Maxillofacial Medicine, Surgery, and Pathology, School of Clinical Dentistry, University of Sheffield, Sheffield, United Kingdom. Our publication is a retrospective investigation entitled Infective Endocarditis Risk Following Invasive Dental Procedures, which appears in the journal Mayo Clinic Proceedings, Innovations, Quality, and Outcomes. And that really says it all, the title, Infective Endocarditis Risk Following Invasive Dental Procedures. Infective endocarditis is a rare, life-threatening infection. And to quantify the risk of a dental procedure, a large database was required. And we used the IBM market scan to quantify 3 adult patient risk categories, that is high, moderate, and low for a risk of endocarditis. And we looked at a variety of dental procedures done within 4 months of endocarditis diagnosis. By the way, this included patients who had healthcare coverage in 3 categories, that is, per employer provided commercial coverage, or Medicare coverage, or Medicaid coverage. The quantification of IE risk following a dental procedure was based on analysis of almost 10 million patients. And this is required because endocarditis is such a rare syndrome. If you had a common syndrome, it would be much easier to study. But if you're interested in endocarditis, then it requires a very large patient population. There were 10 million patients with almost 54 million procedures. The use of antibiotic prophylaxis for these procedures had to be factored into the statistical analysis to permit IE risk stratification. So it's the quantification of the risk that's the key issue and the key point made in our publication. Our findings should be relevant to clinical practice and the management of patients undergoing dental procedures. For example, the risk of developing endocarditis was approximately 125 times greater in those at high endocarditis risk as compared to individuals at low endocarditis risk. For certain oral surgery procedures, this risk more than doubled. Results of our investigation support both the current American Heart Association and European Society of Cardiology recommendations about using antibiotic prophylaxis in patients who are at high risk of endocarditis and undergo certain invasive dental procedures. These findings also highlight the need for further educational research as the next step to identify methods to improve clinician and patient understanding of their endocarditis risk status, relevant dental procedures related to endocarditis risk, and whether there is a need for antibiotic prophylaxis prior to the dental procedure. In the high IE risk group evaluated in our investigation, only 1/3 received antibiotic prophylaxis. Let me say that again. Only 1/3 of the high-risk patient group received antibiotic prophylaxis prior to the dental procedure. And unfortunately, this is not unique. Many studies have shown that patients who deserve antibiotic prophylaxis are not getting it. On the flip side, we also noted that there were patients of moderate risk and low risk Currently, those who are not in need of antibiotic prophylaxis getting antibiotic prophylaxis. So we've got risk and benefits to be considered here, and you have to think about such things as adverse drug events, and from a global perspective, what antibiotic prophylaxis use means and does to the issue of antibiotic resistance among our normal flora. So as we look going forward, I think that this work quantifies the risk of certain dental procedures in a high endocarditis risk population. And we look forward to hopefully improving the educational perspective of both clinicians and patients in regard to who actually needs antibiotic prophylaxis. I thank you for listening to our video, and I hope that this will encourage you to examine our publication and its benefits to your clinical practice.